We can start with a very interesting question. Is it time for everyone to pick up a handheld probe and put down the stethoscope? I'd like to start with a segment from an interview that I did last week with Partho Sengupta. He's the endowed professor, chief of the division of cardiology, and the director of cardiac imaging at the West Virginia University Heart and Vascular Institute. He is on the leading edge of cardiac imaging, and his perspective on handheld ultrasound and bedside imaging is a really good place for us to start. Well, welcome, Partho. It's a privilege, and it's an honor to have you here with us today. I know you well, and I know you've led a very distinguished career thus far, and I know you're far from finished. But for the audience that we have here today, could you share with us now your current position?
Thank you, John. Thank you for having me here. I've been an enthusiast, a technology enthusiast all throughout my career. I'm the chief of cardiology at West Virginia University. I also direct an innovation center, and also I'm very fortunate to have Avnash C. Jain chair endowed position, which allows me to do a lot of creative activities and also allow us to educate and carry out the research that we're so passionate about.
Well, I think you and I have been around long enough to know that the echo lab, if you will, or the image of an echo tech coming to the bedside with a big, large cart is really where we're used to the use of cardiac echo. And this new world of point of care ultrasound has changed that dramatically, just as you've described. Do you see cardiologists embracing this, or are they still wedded to the historic? How much of a change do you think is evolving now that these new handheld devices are around that could literally fit in the pockets of physicians?
Yeah, I think you're fair to say that cardiologists, are they embracing it, and do they feel threatened by it? I mean, that's a second implied question. In my opinion, the problem is big enough. The amount of burden of disease in the community is big enough that we don't need to feel threatened. There's enough work for everyone. I think there's no single technologist, no single cardiologist who's going to have problems with getting work. I can tell you that. The workforce is shrinking, the problem is increasing. There's more number of patients and we don't have equal number of qualified people. So there's no problem about, I always tell this thing to anybody, my fellow. So we have some degree of guarantee of work. So there is no threat. Now, the question is augmenting ourselves with the newer tools so that you can be better. Could you be a better cardiologist? Could you be a better physician? And a better physician is going to replace a person who's not augmented. That's for sure. So the competition is between, are you ready to get augmented and be more intelligent versus staying the standard way, that we have seen in the past. So there is a lot of enthusiasm, at least what I see in the cardiology community, to accept the POCUS for rapid decision making. And I think it also helps the bigger echo labs by having more appropriate transition of care, because you want to not do a normal echo, 40% of the time we're seeing normal echoes being done. Why don't we bring that down and have more number of appropriate echoes? And I can tell you the number of echoes are not going down. In fact, in my routine clinics, I almost always, a new patient comes in and offer a point of care ultrasound, because it's a good one step to quickly know if there are any issues that require immediate referral. So first step, very quickly, within the first 20 minutes, for you to risk stratify what am I going to do with this patient. Structural heart disease is a perfect example. Second place is, which I find also very, very useful, and I think my colleagues in heart failure will agree, is the assessment of the volume status. I love the jugular venous impulse. I love looking on for edema. But it's amazing how much more confident I feel when I see a dilated IVC that's not collapsing and increasing my diuretics. It gives me the enormous confidence to go ahead and do something. Many times, people who have body habitus and you don't see the jugular venous. It's difficult. It's just difficult. And so some of this complexity, I'm not saying you take away from your examination, but if you're not confident whether you're seeing the JVP or you're not, so it's very one simple, quick step for you to be able to triage these patients with the right kind of diuretics and dosing. So heart failure, particularly estimating the volume status, is very useful. And I'm talking about the outpatient clinic. The same applies also for the intensive care and the ED. Volume status is very good with a point of care ultrasound. So I really believe, and even in my inpatient clinic, when we go on for rounds, we make actually some specifically, I tell my residents, okay, this is the goal of the visit. This patient is going to be do the volume status examination and we'll decide the dose of the diuretic for the day. So we go there, we engage with the patient, we do the exam, and we decide. I mean, and most of the time it helps us to be better calibrated.
So as you look out to the future, is there really, and this is a tough question for you, is there really a role for a stethoscope for a cardiologist? Why do you still need one?
No, I don't think you need a stethoscope. I really don't think you need a stethoscope. You can see everything. You can see the lungs, you can see the heart, you can see the abdomen. So I'm more augmented and more confident with the views that are provided. I feel very comfortable not having, I don't have a stethoscope around me right now. You can see that.
We look very much forward to continue working with you and supporting your efforts because you're obviously a very transformational figure in the practice. And I thank you very much for being part of this symposium with us today.
Thank you, John. Look forward to more.
Well, why don't we walk through our panel here, Mike, and we can have them introduce themselves. And we'll start with Noreen. Go ahead, Noreen.
So I'm Noreen Kelly. I am the director of the echocardiography laboratory at Sanger Heart and Vascular Institute, HRM Health in Charlotte, North Carolina. And I am currently leading our effort to expand our use of cardiac POCUS in my institution.
Great. Thanks, Noreen. Robert?
Good evening, everyone. I'm Rob Roswell. I'm the Associate Dean for Diversity, Equity, and Inclusion at the Zucker School of Medicine here at Hofstra Northwell in New York City. I'm also on the Board of Trustees Task Force for the ACC, looking at critical care cardiology and the movement from a workforce or a task force into a true committee on the ACC. I also co-direct the cardiac ICU at Lenox Hill, which is part of Northwell Health here on the Upper East Side of New York City. So thank you for having me.
I don't know why, Robert, every time I hear the word dean, I want to start running. I think it's a flashback from all the times I've gotten in trouble in my career. Ali, how about you?
Hi, I am Ali Haider. I'm an interventional and structural cardiologist, assistant professor of medicine at a UMass Medical Center Bay State in Springfield. I do a lot of interventional as well as clinical cardiology, inpatient, outpatient, CCU, and I'm probably one of the earliest, if not first, adopters of utilizing handheld POCUS in our hospital system, and I'm a big proponent of that. And so do a lot of education, cardiology, cardiovascular health education on social media.
Oh, the dreaded social media. Oh my goodness. Well, this is a good group to start with. So I think the first question I'll throw out there, Mike, and maybe it's not the best. What is your reaction to Partho, who says, I don't need a stethoscope anymore? Let's start there and let's see where you guys and gals go with that.
So I totally agree with a few caveats. So why do you need to listen to the lungs when you can see them? Why do you need to listen to the heart to hear MR when you can see the MR? But I think the biggest gap, and I think your question was, should we put this in everyone's hands now? And the reason is no. And that's because one of the areas we're missing is training on all of this, because it can be a dangerous tool if you don't know how to interpret it accurately. And so I think the reason cardiologists are picking this up is because we've already been trained in echo. And so this is just like the next step, right, to making this right at our hands, but that's not the case for everyone. And so one of the things I think we need to rally around, and I'm a member of the ASC and all this stuff, is formalizing training programs for this so that everyone can be using this, but using it safely, interpreting it accurately, so that we're not making mistakes.
So I would like to chime in here, and I'd like to echo a lot of things that Dr. Kelly and Dr. Sengupta said, no pun intended. But regarding the question,
it was very well played, by the way.
Thank you. I was hoping
keep that up. If you can keep those going, we're going to have a real good evening.
Just came to me. So, so regarding the question of whether it should replace it, my answer is no. It should not be a replacement of the stethoscope. Instead, it should be an extension and a complement to the stethoscope. Okay, because There is a vast amount of information and advantages you can get with a handheld ultrasound. And however, the caveats that Dr. Kelly brought up are super important. The proper training is crucial, because if you don't know what you're looking for, what you're not looking for, you could potentially miss something that you may pick up with your stethoscope. Also, in even the best trained hands, there are situations where you may not get the information you want with a handheld ultrasound. Maybe the windows are not good. Maybe you're going to miss a VSD that you're going to be able to hear with your stethoscope very profoundly, and aortic stenosis. And there are situations I think that a stethoscope is important. But combined with the POCUS ultrasound, it's a very powerful, valuable tool that not only will provide more outstanding care for our patients, but improved efficiency, I think healthcare cost savings. So my opinion is it should be used as an extension.
And I agree, as a medical educator, using the stethoscope is critically important. And I think it just complements everything that you're doing. So if you hear a VSD or a VSR, and you're going to look for it more pointedly with your ultrasound. And so it's really important to use them in tandem. And I don't know why you have to hang up one for the other. I think if we're in a transition, I think this is the part where we will have both, where we have both the stethoscope and POCUS. I don't think that we have to have one or the other.
I'm being a bit provocative, as all of you might expect. And that's the nature of surgeons. That's the way we are. But let me ask you guys a question. And Mike, I want you to jump in on this, because most of you are educators here in this group. What if I fast forward and said it's 10 years from now? We've got medical schools all across the country that are now purchasing ultrasound devices for their students. Most residency programs in many disciplines are including point of care ultrasound in their training programs. Fast forward 10 years from now, is your answer exactly the same?
Mine is, but I also said we don't need it right now. So, in the right trained hands, obviously. No, I mean, it's one of those things where, right, you've got to do it over and over and over again to get good at it. And so part of what I think the tension between having both is that, as we know, one is going to get better, then people aren't going to be doing, listening with the stethoscope as much. They're going to lose their skills and things like that. And I think right now, there's not many probes out there that I think are perfectly adequate to replace our, actual echo carts. But I think 10 years from now, that's not going to be the case. And it's going to be hard to miss a VSD, because our probes and our technology and our imaging are just getting better. I mean, look at what has happened with, our actual echo carts. I mean, the 3D pictures we can take now are, rivaling CT. The newest upgrades on machines are doing 3D processing, similar to what you're doing with multiplanar reformatting on CT, and that just keeps getting better and better.
Yeah, I was going to say, what happens in that worst case scenario where you don't have ultrasound, or the electricity fails, or the battery fails, or some situation happens where you can't get hold of one, and then you have this situation where no one really knows how to use a stethoscope. No one knows what's going on when they listen to patients. And stethoscopes are so easy to carry around wherever you're going, out of the country, on planes really easily. So I think they still have a foundational root in medicine. What impact they have, what part they'll play in the future, I think is going to be less over the years. But it's hard to envision a time where a healthcare provider does not know how to use a stethoscope. And I think, just thinking about how we use innovation and technology and where we have to think about places that don't have that technology, or where you won't have access to point of care ultrasound. And you have to have the skills to know how to treat a patient when you don't have innovation at the ready.
To Butterfly's credit, though, they're going to be like the same price as a stethoscope, or cheaper, probably. And you can't really get by without a phone. And I think I hope as a country, we start investing in technology, because I think, if anything, hopefully this pandemic made us realize the health disparities and stuff that is related to lack of technology. And we invest in that infrastructure, so that I hope that that's not the case I hope 10 years from now, we've invested in some of this and overcome it.
There's so many really amazing points being made here that, when the stethoscope was first invented, there was a lot of the same hesitancy about the dangers that could come from its improper use. And I would say that, speaking for myself and as an emergency doc, and for John as a surgeon, I don't know that we really think we can do the same thing with the stethoscope that maybe Ali and Rob and Noreen can do. So I'm not sure that I'm any, I mean, I know for a fact, and maybe it's years of playing music without earplugs, I'm way better with an ultrasound system than I am with a stethoscope. And in my own personal practice, I don't carry a stethoscope, but I also have access to ultrasound every single shift that I work. So, I mean, I do think a lot of the points being raised are fantastic. I know we're going to dive deeper into training because, you know, I don't know how much training everyone listening or everybody on this on as a panelist had with the use of their stethoscope. But, you know, I don't think I had enough to gain mastery. And a lot of it is repetition. A lot of the same training is required for ultrasound. And you know, some of the barriers to training are really, I think, fascinating areas to explore, because it's not like there's anything really stopping providers from getting good with a handheld ultrasound to the point that they can really make important decisions. So I'm sure we'll dive deeper into that. And sorry, Ali, I didn't mean to cut you off.
No, I mean, it's all excellent points. And I'm glad we all got different perspectives here. But, you know, to me, again, to answer the question, you know, many years from now, I think certainly the stethoscope is going to take a little bit of back burner. You're going to keep that in your pocket, and your primary weapon is going to be your ultrasound, certainly. But, you know, to Dr. Roswell's point, your iPhone could die. There could be technical issues. If you don't have the skill set to, you know, use that stethoscope, have it available, you're going to miss a very easily diagnosed condition. To me, it'll never leave your pocket. Like, call me old-fashioned, even though I don't feel I'm that old.
Well, I threw that out there, and listen, I'm a vascular surgeon, and I was the president of a large cardiology group, and they constantly made fun of my stethoscope skills, but I kept trying. And I'm with Mike. I'm not as good at it as you guys are, but I certainly tried hard. And I threw that out there just really to challenge the conversation, to see where we're going. And I was hopeful that it would spark toward these kinds of conversations, knowing where one is helpful and the other isn't. And then also the education question. So why don't we throw that out on the table? Let's think about what are the use cases in which we think that it makes a ton of sense, actually, to use point of care ultrasound, and what is the pathway to get there. I think one of the things that we think differently about, and I credit Mike to this, is instead of thinking about a technologist that takes 2 years to learn this, or an ultrasound fellowship, are there segmental ways in which we can learn specific use cases, gain confidence, and then expand the way in which we use ultrasound? Can you guys discuss how you would encourage those of us that are not as sophisticated in ultrasound to learn quickly to use this device to our advantage, and what would those use cases be?
So I think in medical education, what we're doing now at our School of Medicine, we have a whole ultrasound curriculum. And so we just go through the basics, going how to identify anatomy, vasculature, looking at the heart, looking at, you know, ejection fraction, looking at pericardial effusions, just the big things that people need to know. And I think it's important just to cover the basics in some sort of educational curriculum that you can get across quickly, like those basics. And you could also do that in residency, so that when people really need these things, like if somebody's having tamponade or something else, they know how to look for the big things, not looking for very nuanced things that people who are more skilled can do. So I think that's what we're doing at the medical school. So with every generation that's coming out now, every class, we're seeing people who are more skilled, more accustomed with ultrasound.
My current feeling is that the current technology is really good enough to answer a small number of questions. So effusion, ejection fraction, you know, probably not dissection, honestly, but fluid status, you know, is your IVC collapsible, things like that. But, you know, I don't think it should be used for valvular disease. You know, I'm director of our echo lab, and there's just too much missing right now in the technology to be using it. But, you know, I'm currently trying to search out how to train this. And I just go to another level that we need an advocacy, right? So we want to train our APPs. We're very NPPA practice heavy and heavy practice, excuse me. And, you know, we are having to push through getting accredited to train people, because there's no universal policy to say, like, okay, you take this course, you pass this exam, you do this many studies, and you've demonstrated competency. I mean, the ASE has some guidelines around it, but I think as, you know, a group, we need to come together and formalize this so that it's easier to get people accredited to do this. And so we know that we're doing it in a safe way. But I think right now the use cases should be small enough that hopefully it's not hard to give people examples of people that have large effusions, people that have normal EF and reduced EF. And I really think it should be kind of that binary categorization, just with where the technology is at right now.
I completely agree with that. I think this needs to start being started earlier in the course of education. Now you see it's very variable how we're seeing it. In our institution, the ER program does have a formal ultrasound training, how their internal medicine does not. You're going to see a lot of, I think, heterogeneity in how people are doing it. I think this should start, as early as, some med school or even residency, and start off with the basics. And I completely agree with Dr. Kelly talking about the basics, right? What are we really going to try to get out of a cardiac POCUS? Tamponade, overall sense of EF, not even segmental wall motion in mouth. Forget about that. Maybe RV instead of PE and IVC, the basics. If we can get across that and let people understand and put into these training programs, look, yes, you can see all this other stuff, but this is what you're going to be validated to analyze with this, and let's keep it at that. That way we're going to minimize false positives, false negatives, misses, and all these sorts of things. But I think this is, it's already starting in some med school levels as well. So we just have to, we got to focus the POCUS.
Focus the POCUS. That's 2 now. We're going to start keeping track of.
All right.
Let me throw one more out there. What do you guys think about the use of point of care ultrasound during cardiac arrest?
Well, I would just tell you in the CCU, I think is really important. So there's a case recently when, he was about 45 years old and was in the CCU post-MI, and all of a sudden got completely hypotensive and was going to PA arrest. We had point of care ultrasound, looked on right away and saw that he was developing a pericardial effusion and he had a free wall rupture. And there was no way we would have figured that out any other way. I think, and we were able to get a pericardiocentesis. He was able to be stabilized. He actually had that's a very rare complication, and he actually lived and survived. And I just thought about it and I was like, wow, if we did not have ultrasound available just to see what happened, I don't know what would happen to that patient. So I think it's really important.
You would have used your stethoscope, Rob.
Right. Our
Touche.
The rub would have given it away.
So I just think that, especially in cardiac arrest codes emergency, you really need it to look for the things that we're talking about, like the effusions, the ruptures, the gross decrease in ejection fraction. Those things are important that you can't get with the stethoscope, Dr. Stone.
I agree.
I agree with you. I agree with you. I think there is one nuance I'd add to these perspectives, which it's amazing. Even though we're trying to be a little provocative and stir up a little bit of controversy and disagreement intentionally, obviously, like the Venn diagram has a ton of overlap. I think the idea of training people to look for binary yes no decisions and focused applications for point of care cardiac ultrasound. Is there an effusion? Yes, no. Global LV function, et cetera. That's emergency medicine, and we've got some other ER docs on the panel who'll be coming on shortly. We're not trying to brag, but we've been doing point of care ultrasound for 20-something, 30-something years, and it's always that approach. Are there gallstones? Yes, no. Is there nice, John? Is there an abdominal aortic aneurysm? Yes or no? But the interesting thing about training for focused yes, no decisions is that as you gain repetition and you gain experience, all of a sudden you start detecting things that you weren't trained to detect. So when I was first in residency, looking at the aorta, it was aneurysm, yes, no. I can't count how many times I've seen a dissection on aorta ultrasound, even though I wasn't necessarily looking for an aortic dissection. And likewise, cardiac, we've picked up ruptured chordae and flail, mitral valve. We picked up mitral stenosis, aortic stenosis, endocarditis, thoracic aortic dissections, all of which, as you gain those core skills and you just start incorporating it into your practice, I think it's really important to recognize that you're going to then identify a whole host of other pathologies that it's, all it's going to do is shorten time to diagnosis. You're still, when I identify an aortic, an intimal flap in the thoracic aorta, doing a parasternal or even a suprasternal notch view, those patients are still going to CT angiogram. It's not like I've now made my POCUS decision and we're altering the standard of care. But training for those core binary yes/no questions is a great way to get started. But really, the sky's the limit as you start to gain experience and expertise, and it becomes a little bit sort of like POCUS plus. But I do agree. Start small. Start with the basics, and then see where it takes you.
I think you made a really important point, though, that it's not meant to change the next step you would usually do in diagnosis. It's meant to shorten the step. So, I shorten time, right? Like, so if you see a flail mitral valve, that person still needs a formal echo, right? Because we need to see, does their tricuspid need a ring when they go to surgery? Is there, any of this other stuff going on? And so, again, I think that's all about education, though, right? Because it's super important. And we have this informal echo too. And I constantly emphasize it as the director of the lab. Like, you have to make sure people know what we are not seeing and what we can actually say confidently. Because you can't just make assumptions because we didn't comment on it. It was normal. We really may not see it. And so making sure that people understand the limitations of POCUS and then still go on to get the formal diagnosis, like diagnostic test, like an echo, like a CT, whatever it is absolutely critical to keeping patients safe.
Yeah, there's two things there I would add. One is that it shortens time to diagnosis when you have a positive finding.
Yeah.
It eliminates a whole lot of unnecessary testing when you have a normal finding. So when you're concerned about whether the patient has a pericardial effusion and you look and they don't, that's a comprehensive echo that you didn't need to order.
Right.
So you're definitely able to get and let's be honest, that's more cases than not, where you suspect a disease, you look for it and it's not present, or a finding it's not present, than where it is present. And the last is a total stickler nomenclature issue that I've been waiting to get into a discussion with a cardiologist at some point about. My point of care ultrasound exams are formal. They're not informal. It's a comprehensive echo, or it's a focused or a POCUS. But the same way when I activate the cath lab and call Ollie's equivalent in at 2 a.m. for a STEMI, that's a formal interpretation of an EKG, even though I'm not a cardiologist.
And I think he wears a tux and a tie every time he does one of these things. Just
I have a bow tie. I have a bow tie on the ultrasound system just for that reason.
And I think this has been great. I think it's a wonderful discussion that we hope to get to. I think we can all agree that there's a role, and cardiologists are adopting this and understanding the focused exams, that training is a key part of it. So you guys hang on with us, because we're going to bring in some new folks that are not cardiologists. You guys are obviously the keys to Echo, but we're going to have some non-cardiologists join Mike. And you take it from here, Mike, and let's see if we can stir the pot even more.